Right, so good evening, everyone, and welcome to the 16th session of the Ocular Genetics Interest Group meeting. This is the Stephen Johnson Syndrome Awareness Month, and as was priorly decided, we are having a session solely dedicated to Stephen Johnson Syndrome awareness. We have two delightful and renowned speakers with us. The first speaker is Dr. Virender Singh Sangwan, and much of you on the who have joined the call already know him. I will still give a brief introduction for Sir. He has more than 25 years of experience in ophthalmic surgery and pioneered the SLED technique for limbal stem cell therapy. He has held positions at LBPI and affiliated with Harvard Medical School and Orbis International. He's currently the Director of Innovation and Translation Research at Dr. Shroff Charity Eye Hospital. And I'm sure this number has increased since the last time this slide was made, and he has several book chapters and publications to his name. After Dr. Sangwan's lecture, we will have Dr. Mehak Vora. She's a PhD in stem cell biology and immunology, and she has done her postdoctoral training at the Department of Ophthalmology at USF Tampa. Her expertise are in ocular surface biology, corneal regeneration, stem cell immunomodulation, in vitro and in vivo disease models. Her research highlights include corneal epithelial homeostasis, bioengineering, and regeneration of cornea. She has several publications in high index journals and awards to her name. And with that, we'll begin our session, and I will hand over the platform to Sangwan sir to take over and start on the clinical management of SJS.
All right. So should I start sharing my slides?
Yes, sir.
All right. Are they visible?
Yes.
Uh,
Slide
how
screens.
how do I hide the view?
Bottom.
Okay.
What?
Yeah, that's fine. So I would is that visible?
Yes.
Yeah, thank you, Ria and Selja, for this opportunity to share some experiences with the Steven Johnson syndrome. And I will start with this particular case, which we managed recently. It's a 12-year-old boy. Everybody can hear me? Ria?
Yes, sir.
Yes, sir.
Yes,
Clearly.
sir. You're audible and visible.
Thank you very much. So this boy had a history of acute conjunctivitis, which was very fulminant, with some ulcers in the mouth following a fever, and he presented to us in quite early in the history. So we gave him IV methylprednisolone, oral steroids, and amniotic membrane transplantation in the acute phase. And these are the pictures 1 week later, 6 weeks later. This is about 6 months later. You can see that it seems quite okay with that treatment, and he did not really develop any very serious chronic sequelae. Another boy, acute or subacute phase, more severe problem than the previous one because his involvement of the skin mucosa was much more, and he's 10-year-old, had undergone similar treatment of IVMP, oral steroids, and then MMG, AMG in the acute phase, AMG, then cataract surgery, and he's okay. I mean, he's slightly better, but not very good. So another case managed long back in 2008, presented in this manner with ulceration on the mouth and or the lip mucosa, underwent amniotic membrane transplantation in the acute phase. And you can see the amount of reaction that it is, on the tarsal conch. Very thick. I'm trying to remove it, but it's coming out very slowly. And then what we did was we put the amniotic membrane on both the tarsal conch and examined this membrane histologically, and we found that there is a tremendous amount of inflammation. And this inflammation focus around the tarsal conch indicates that there is something, probably some antigen or some target, immune target in the lid area. because these patients continue to have inflammation in the tarsal conch. And he received the similar treatment which I mentioned, and he did reasonably okay, not excellent, but I would think that he did not develop very serious sequela of SJS. Another lady who's more than around 15-year follow-up presented slightly less acute, this ulceration on the mouth and the lip mucosa and similar membrane, underwent all the procedure you can think of: amniotic membrane, systemic steroids, and then the AMGs, MMGs, repeat MMG, cataract surgery, and has been using Pros lens now about 20 years, 21 years follow-up, and also comes here from Hyderabad to meet me sometimes. And she's been doing okay in one eye. The other eye did not do that well after 15 years. So these scleral lenses are a special kind of lenses which are fluid filled, and they provide protection from eyeball, from the eyelash and the lids. They have prevent exposure keratitis, enhance epithelial healing, and also there is an optic neutralization of irregular corneal surface. And for those who may not know, these scleral lenses we brought in India in 2017, and a manufacturing happening in LVP, and everyone gets from there.
They told me my eyes were melting away, both of them. And they fed me here to LV Prasad Eye Hospital in India. When I met Dr. V.S., my vision was zero because my eyes were not even opening at all. There was nothing like left on the eye. He said he wanted to do an immediate surgery for the complete reconstruction of both eyes. He said I had to give my eyes time to heal. After that, he was going to do a corrective surgery to improve my eyesight. So as the eyes were healing, sight was restored on the right eye. I went through a cataract surgery, and like now my eyesight on the right has improved from 0 to 40%.
So this lady came from Zimbabwe, and we could restore a little bit of vision, at least functional, around 40-45%. Some of you may wonder, why did I got interested in SJS? When I came back from Boston in 1998 March and joined LVP, almost all the cornea specialists, there are about 6 or 7 of them, they said, Virender, what you will do? We are doing everything. There's not enough work. You should think whether there is enough work for you. I said, I will not touch any kind of cases that you are interested in. Send me those patients which you think that you cannot take, or you don't want to take care, or you think that nothing can be done. And guess what I got? Mostly SJS, acute chemical burns, chronic chemical burn, OCP, very severe Moran's ulcer or VKCs. And that is what I have built my career on that. And that's why SJS has stuck with me. And I just want to highlight what had changed in last 20-25 years. If you look at the incidence in India, it's quite high compared to Western developed countries. And there are many reasons, and there are many theories, and maybe different explanations. But the fact is that we see much more. And in my practice, I think about 40-50% of my OPD is SJS patients, and rest is chemical burns or other such conditions. If you look at the published literature, this condition was described somewhere in 1946, and between 1946 and until maybe 200 or before, there was hardly any development, new development for this. From there, in last 25 years, if you look at the peer-reviewed literature, there is a tremendous increase in a number of publications. For the first time, we reported in 2001 use of amniotic membrane for management of SJS. This paper was published in Ophthalmology Journal. And then we had also started doing cataract surgery. And when I discuss cataract surgery in SJS, Most of my seniors said it's Pandora's box. If you touch, it will be very bad. I did not really take it that way. I thought maybe I should try. And I think in 2005, we published first paper of cataract surgery in SJS in Journal of Cataract and Refractive Surgery. When you look at the acute manifestation, this is one of the most devastating condition in which in SJS or Lyell syndrome, about 10 to 30% people die during the acute phase. Those who survive, there is a severe consequences to the ocular surface and vision. Even if those patients who see, they have very difficult life, and they're always having light sensitivity, difficulty in seeing, and irritations, discharge. So it's one of the most challenging conditions that we face in terms of the management. Think about the patient there and their life. I will just give you an example of a unhighlighted topic in the literature. There was no mention of pediatric SJS before this study, which we started and then reported on the outcome of 523 eyes. So we looked at the non-keratopathy group. We looked at three areas: upper, lower tarsal cons, and bulbar conjunctiva. And this is how we categorize. So in this series, about 14% of the patient had no keratopathy. They did not need any significant management other than lubricating drops. The second group was non-lid related keratopathy, meaning they had a keratopathy, but it was not related to the lid margin. And this was 23%. Again, in these, most of these patients used Prose lens, which I have been having since 2001 in my practice and used to get from US. Third group is lid-related keratopathy. This is the lid margin which becomes very rough, keratinized, and 21% of these eyes had lid margin-related problem, and they underwent MMG. This was very early data when we started doing MMG. So this children had 16 eyes, underwent 16 lids, and Prose lens in 18, and mostly or them also received topical lubricants. This is the end stage. If you look at this is 42%, and they have severe lid margin problems. They have ocular surface problem, dry, dermalized, or they reach a stage there nothing can be done, or that was what was considered at that time when I started my career in 98, 99. One of the obstacle even today remains 50 to 70% of these patients don't present to the ophthalmologist in the first 2 years. They present anywhere between 2 to 20 years later. And many a times, even today, the diagnosis of SJS or Lyell syndrome is not made easily in the primary care settings. When you look at the chronic sequelae, this is the summary of those results I told. So about 45 plus, say about 60% of these eyes have severe problem, and many of them can be prevented. And I'll show you through the data what is possible. See, when you see the keratopathy due to lid disease, what does it mean? Look at this young boy, very energetic young boy, and gets acute SJS. And in the beginning, not diagnosed. He has very severe manifestations on the oral mucosa and the eyelid mucosa. And he's going around with this dermalized ocular surface in the one eye. The other eye, most of the doctors have not even looked at the left eye. So this was 2013. This is how he presented. And simple intervention with lid margin MMG and punctal cautery, the left eye improves. And 2015, he almost improves a vision of 2040. So it has changed his life. We may not be able to do much for the right eye, but the left eye, he's able to go to school and do normal life. And primary culprit in all these patients, and most of these patients, is this lid margin. And lid margin becomes keratinized because of the persistent inflammation. That is the nature's protective mechanism. Look at the, first, if you use only lubricants, mostly these patients will continue to lose their eyesight. If you use Prose lens in addition to lubricants, they will do slightly better. If you do MMG, they will do much better. If you do both MMG and Prose lens, and this can be the life-changing experience for these patients. For example, these are the patients presented to us in LVP in 2008, 2009, and 2013, and look at just in 6 years, the surface becomes totally dermalized. This another in 4 years. This another 1 year. So this is the only window where we can intervene and change or alter the course of the disease. At least partially, you can save the vision. This is a patient whom we managed. In the right eye, he was 2400 and left eye 2020. The underwent MMG, both lids in the right eye, and left eye did not have much problem. He didn't want to wait. He didn't want to have the surgery. And a year later, you can see both the eyes are 20/60, and that has deteriorated and the other eye has improved. So in this, there is a lot of evidence in the literature that is no-brainer. So it's a one technique which not only cornea surgeon, the eye surgeons should learn and manage these patients wherever at the earliest opportunity. Just to give you a magnified view, this can be as bad as keratinization like what you're seeing here. And this, if you do a nice MMG, lip mucosa harvested and transplanted here, it can become again very useful. And this is the highly magnified view of MMG before and a normal lid. Now you look at the keratopathy due to dry eye disease, meaning non-lid related keratopathy, where there is no lid margin keratinization, but there is a keratopathy and dryness. For this, we started doing and developing a technique called minor salivary gland transplantation or MIST. And if you see this result of this technique, it's not very dramatic, but the eyes improve, the moisture improves, and the surface becomes much better. And this is how, after a month, the gland and the upper tarsal bulbar conjunctiva look like. This is the eye which is before and after 1 month post. So if you are able to do a restore, like do a MIST, do a lid margin MMG, maybe punctal cautery, and still there is a pannus or there is other things, you can consider allo slat, but that you should do only if you have managed a lot of patients beforehand. This is the end stage, and in end stage, this is how the appearance would look like. And when I started reviewing literature way back in early 2000, these are the only reports were MOOKP, which was mostly done by Professor Falcinelli in Italy, and maybe another one place in US, and Donald Ten was doing a little bit. And another was Boston type 2 keratoprosthesis, but not practiced outside Boston. So I started learning this MOOKP with Dr. Srinivas K. Rao and Geeta Iyer, and understood that this is a very complex surgery involving 2 to 3 hours at each stage. And I started doing breakdown into 4 stages. And this is, you remove everything inside the eye except the retina. You remove the lens, vitreous, iris, and then after some time, you do the oral buccal mucosal transplantation. And after that, you harvest the tooth. And then it's a very, very complex procedure. In SJS patient, there were no well highlighted reports. We published our first paper in 2013. 80% of these patients had mucosal problems, serious problems. And those who got good vision, they hated themselves. Most of them had cosmetic issues. So we understood that this is a very complex, extremely demanding surgical technique. It's a multi-stage, and it may not be possible for a cornea surgeon to incorporate into his or her practice unless it's a group dedicated, like in Sankar Nethralaya, they have a dedicated team doing only this procedure. Then I encountered, while we are doing these MOOKPs, I encountered this girl, and I suddenly got an idea that what if we do a buccal mucosa and then do a K-Pro under the mucosa, and that was the birth of LVP K-Pro. And Sayan was a fellow at that time, or maybe just joined as a faculty. So in this girl, what I did was, I did use the Boston Type 1 K-Pro, and the cylinder was, the mucosa was little over riding the margins, and the vision immediately improved to 20/100. And over a period of time, the mucosa will grow back, and you can't see where the cylinder is. So she will come back, doctor, I've lost the vision. So then I will open the mucosa, and multiple time I did in her case, and finally the mucosa stopped growing. And from there got the idea that if we design the K-Pro in a way that it's about 0.25 millimeter above, the margin, above the mucosa, and it fits into the neck. So that is how we designed an Oro K-Pro, LVP K-Pro, what we called it. And this is the concept of doing the K-Pro. You transplant the mucosa in the first stage, and then at the second, after 2-3 months, you lift up the mucosa and do like a Boston Type 1 K-Pro. There's not much difference other than the size. Sorry, this video is not running. And you can see this outcome. Like this girl had a reasonably good vision at this stage. If we have done the MMG, would have been a different outcome. But we lost that opportunity. Then she underwent a LVP K-Pro, and excellent outcome. So when we compared the outcome of LVP K-Pro with the Oro K-Pro or Boston Type 1 K-Pro, these are 55 patients, and their survival, 3-year survival, is 78%, really far better than the MOOKP. At that stage, we decided that we'll not be doing MOOKP. We did 30 patients and then followed up. And after that, we exclusively switched to LVP K-Pro for end stage conditions. And these are the visual outcomes. Please feel free anytime if anyone need to ask or make a comment or discuss a point. And these are some of the post-op appearance. Cosmetically far better because the lid still closes over it. And then, the K-Pro has evolved. LVP K-Pro, I now use pannus, I use mucosa, I use, Tennant's patch graft. I can use the lid also. So it depends what is available. And in the process of building this practice, we had the privilege of, being trained by the best in the field. And I had these two young cornea surgeons, Vinay Pillai and Sayan Basu. We had training from Dr. Dolman and Dr. Chodos, Dr. Jim Akwavella, who was the first fellow of Dr. Dolman, and Professor Falsnani in 2010 spent 1 week with us teaching us MOOKP. Now, just to give you an idea about the cataract surgery, just because we talked about it, these are some of now we have reported the largest series, and that was done in 2014. Purvasa Narang, she was a short-term fellow with me, and she looked at the outcome of cataract surgery in Stephen Johnson and published in BJO. And even till date, this remains the largest series. And for me, doing SJS cataract surgery routine, I haven't seen any serious complication which is specific to the SJS. So this has been a really good development for these patients. What kind of problem persists? Still, the patients having such a kind of a dry eye despite having punctal cautery or mist. Some of the patients not very happy. Epi defect, if the patient develops in SJS patient, very serious problem. We don't have a very good solution. So if you look at in the acute phase, there are two interventions that you can do is IV methylprednisolone after ruling out any systemic infection. And if you can do the bedside or manage to bring the patient in amniotic membrane transplantation. In the chronic phase, MMG and PROS. For dry eye, keratopathy, mist, and then if you have done and managed the surface better, you may be able to do a slit in selected patient. and it will always be yellow, so systemic immunomodulation is required. And very advanced end stage, we think only LVPK Pro is a good option. So in summary, it's a very complex disease. What we have developed, these 5-6 procedures in last 25 years, but I think there's a lot needs to be done. But the timely intervention is crucial in progression of the disease, and the window provided is very narrow. We need to act very quickly. While we develop new techniques, new technologies, it's very important to develop a network, a group. Now, I'm very happy to tell you that there is a huge number of ocular surface surgeons around the country and internationally. When I started, there was no one who was dedicated on ocular surface. We made this ocular surface interest group, which is very active on WhatsApp, and we do have these conferences periodically. So I think it's a very good mechanism of spreading this knowledge, and I hope it will continue and refine it further. Thank you very much. Ria?
Thank you, Dr. Sangwan. Amazing presentation as such, as all the time. I mean, I was glued to the screen. So one question, sir, you showed cataract surgeries in SJS patients.
Yes.
You had made a scleral or slightly scleral incisions in both of the
Not
patients.
slightly. I make scleral only.
Yeah, scleral only. So is it suggested to make scleral and should avoid a corneal incision in such patients because there are surface and epithelial issues in them?
No, it's not a question of avoiding. I think it's the technique that you should practice what is best in your hand. And so
Okay.
because I was trained as an ECC and ICC surgeon, so I find that I can do cataract surgery with a limbal or posterior limbal incision with the closed eyes. So I always fall back on my technique, which is the best in my hands. And I have not seen any problems. I must have done more than 500 cataract surgery in SJS patients over last 20-25 years. I haven't seen any unusual problem or healing problem. But now I do use amniotic membrane. And hopefully, Shiti maybe sees her fellowship project. Hopefully, she would complete that project and write it up. We are using a very unique technique, which is very useful.
So closing it with the AMG or something like that.
No, closing because the sconge is shortened due to fibrosis, so we'll make incisions, release those fibrotic bands, and if the fornices are shallow inferiorly, I release those also, and then either use the amniotic membrane only on the wound so that I don't have to pull up the conjunctiva, or we do a 360-degree conch so that the fornix are deeper and we are able to use a prose lens post-operatively.
Yeah, thank you.
Yeah, so just another question, sir. We are discussing SJS here because most literature on SJS begins with the line that it is a very rare disorder. But what we know in India that the prevalence is quite high compared to Western literature. What do you think is the reason that we see so much of ocular SJS and systemic as well in India more than the West?
I think a few reasons. One, I think the quality control on our medicines is not very high. So these are spurious or substandard medicines is one of the reasons I would think. Secondly, I think the doctors or patient or the pharmacist giving medicines without any proper prescription, that also would contribute to these. And third is maybe there are some genetic factors which we don't know. And this is an area that we need to study, and Mehak will enlighten us with some insights that what I had the little bit of a work with Professor Kinosita early on, genetics, genotyping and phenotyping. So not a whole lot is known about this. But I'm very happy to note that there are, two PhDs in our group. Mehak is invested in SJS, and there are PhDs from AIMS, from Sankar Netralaya, from not Sankar Netralaya, LVP, Narayan Netralaya. So the whole mahol looks very interesting and exciting now, at least for this disease.
So one more question. Why do you think it's more common in children also? Again, this similar kind of reasons or?
I don't know. I think the kids are more prone
Yeah.
to these infections or maybe overly active immune system. I really don't know, but this is another area that we should investigate rather than speculate.
Yeah.
There's another question on the chat.
Hi.
Surbi, do you want to ask yourself or do you just want me to read it out? Oh, there are more. So she's asking, do autologous serum drops help in the early SJS disease to slow down the ocular complications?
I have used these things very early on, and I'm not very impressed that they slow down or this thing, because I've tried almost everything. So I'm not very particularly a big fan of the serum drops. But what might be helpful, maybe use of plasma, what do you call platelet-rich plasma, which we have not tried, and Mac has been telling that we should try. So maybe we should develop a mechanism of using this, at least in patients whom we are doing surgery.
So my
There's
question,
another question. Okay, sorry, Mehak, go on.
yeah, one question. So, like you said, like you see a lot of cataract patients in SJS. So, is there some kind of association with, suppose if I say there's a drug reaction, and within stipulated duration, you see aggressive formation of cataract in these patients? Is the duration of the disease associated with the cataract? That's my simple question.
No, the reasons for cataract are multiple. I mean, one, the inflammation itself is so severe that it will impair the metabolism of the lens, crystalline lens. Number two, we use so much of steroids; they will contribute, iatrogenically, and also maybe because these patients are high. You have a referral bias. In my practice, you are so much referred, but not everybody sees so many of patients, and most people don't do cataract surgery now. At least in big centers like Shankar Nethralaya, LVP, Narayan Nethralaya, AIMS, us, we are doing cataract surgery in these patients, and good cataract surgeons are able to do, even if they don't manage SJS, they are able to do the cataract surgery in these eyes.
And the second question is, as a molecular biologist, this has been my question always. Like, you when you do MMG, and when we read the definition of SGS, we always say there is a involvement of mucosa, where oral is also one of the mucosal that we say is involved. But now when we are looking at MMG, we are using the same mucosa of that same patient and putting it on the lid. So would you consider that oral mucosa, knowing the fact that it is also prone to a reaction or might have been in the acute phase, is healthy that we are putting it into the eye?
Yeah, of course, that mucosa is involved, and I've done as early as like 6 weeks when the mucosa, oral mucosa itself is very inflamed. So before, in the subacute phase, we look at the lip mucosa and mouth. If the lesions are not resolved, we will not take that mucosa. But once it is healed, I think the oral mucosal healing mechanism is much different than the the
Surface.
mucosa of the eye.
Yeah,
So
that what
there, the
explains it.
fibrosis may be happening, but it's such a widespread, and the stem cells in the oral mucosa are widespread. They are not focused in a particular area, so the impact is less. But when we are harvesting the lip mucosa, you are able to make out which area is healthy, which area is not very healthy. So the effect may not be universal.
Yeah, that makes sense, Mehak, to even study that. Like, what are the differences in that healing, which, or maybe even the characteristics of the oral mucosa versus the
I
uh,
think it's a very good question.
conjunctiva.
Mehak.
Yeah.
Say we can work with Dr. Seema that they do oral mucosa, or maybe we can take volunteers. Like when I started working with the oral mucosa in 2004, 2005, I myself, my lab students, we used to give 3 millimeter lip biopsy ourselves, and
Hmm.
that becomes your control.
Yeah.
There is another question from Dr. Prasad. You're unmuted. Yes.
Yeah, sir, one more question. It's a
Yes, sir.
little different question. Any special precautions, maybe pre-operative, post-operative, or intraoperative, while doing the squint surgery? Because some of these patients do require some cosmetic
Yes,
surgeries and
they
they are
do.
insistent in
Yeah,
squint surgery.
yeah. I think there are a couple of things that you can think of. That first, pre-operatively try to control the inflammation, but you will never achieve a white eye in these patients.
Yes.
So that is something that you should remember, that if you keep waiting, that day will never come.
Yeah.
So control pre-operative topical steroids, and then when you do the surgery, try to do surgery in a way where you are able to dissect the conch, and if there is not enough conch for you to suture back, use the amniotic membrane,
Oh,
even over the muscle.
yeah.
And what else you can protect your epithelium, corneal epithelium. Be very, very gentle and nice. I use like methyl cellulose on the corneal surface
Yeah.
if I am doing MMG, or maybe use a bandage contact lens, and on top of that use methyl cellulose, because the epithelium is so fragile. Once it comes off, the healing is a
Is very
nightmare,
good.
Yeah.
and it will always result in a scar. So you may really treat the squint, but may end up having a corneal scar.
Yeah. Yeah. Thank you, sir.
So another question, Dr. Meena, would you want to unmute?
मीना की आवाज सुनने दो भाई. मीना.
Uh,
Okay.
I'll read it out. So
Yes,
she's
please.
asking, can you tell why minor salivary glands can be healthy? I am not sure what it means and how long and difficult it is. Probably she's trying to ask about the surgery of minor salivary gland transplant.
So, yeah, Meena, do you want to clarify?
They don't get involved at all in it.
No, they do get involved.
So because when you do the surgery, how do you know that they will work?
So,
I'm not sure that.
yeah,
that is
I
correct.
understood. Meena, your voice is little faint. I understood the question that you're asking. How do we know if the the minor salivary gland we are harvesting is healthy or not? If you read a paper by Swati Singh, I think Swati Singh is another young researcher, a surgeon, clinician, scientist who is doing amazing work in SJS. So see, I think a couple of years back published that you can do a fluorescein test of the lip. You put a fluorescein strip, hold the lip, and see how you can see the glands secreting, like what we see Siedel's test in the surface. So you'll see those glands which are active. Number two, when you do surgery, see areas which are little more pink, and avoid areas which seem little grayish or not as pink as your normal lip would look like. So you will have to identify that area and generally take a rectangular piece. When you do mist harvesting, you have to go a little deeper as compared to oral mucosa when you're harvesting, because glands are sitting right on the muscle. So you go quite deep and have the whole block, and then use the superior rectus. You can hook the superior rectus and suture right at the insertion of the superior rectus and cover with the conch. So you'll obviously open the conch superiorly. Any other questions, or we go to Max?
Yeah, there's one last question, which says how to prevent progression of ocular surface disease in SJS in the chronic phase, from Dr. Vidya Shankar Kulkarni.
Vidya Sankarji, very good. Vidya Sankar, there is really no definite mechanism that you can prevent the progression. But what I have seen, if we have done early stage MMG, even if there are no surface changes, and if you are able to do a MMG both lids, or if not both lids, both upper lids, I think you can slow down the damage for the corneal and ocular surface. The patient will be much more comfortable. They won't be 100% normal, but you can slow down the progression of keratopathy significantly. And if you use prose lens, that will add another level, because the prose lens works during the daytime. We have to remove at night. So if you have done the MMG, what do you call these moments when you're sleeping, the eye moments?
In REM sleep movements,
Yeah. So when the eyeball moves, the rough lid margin will still damage during the sleep. So if you have done the lid margin MMG, it will protect the whole eyeball and the cornea. So that is these two interventions are very important. And another simple one will be punctal cautery.
I think those are the
Thank you.
questions.
All right, Mehak, your molecular insights.
Thank you, Dr. Sangwan, for setting the stage and making my talk even more comfortable, because you know what I'll present molecularly, I guess you would be now able to more connect with it molecularly. And I thank Dr. Shailja and Riya for giving me this opportunity to present today. So I'll be sharing my screen. So is my screen visible?
We are not able to see your slides yet. It says
Is it visible
now,
now, sir?
now visible.
Just give me a moment. So good evening, everyone. I am Mehak Sapra. I'm a research scientist in Aisha's from Center for Stem Cell Research. My presentation will mainly focus on molecular and genetic aspects of Stevens-Johnson syndrome. So to give you a brief recapitulation of the disease, SJS, or its more severe form, which is toxic epidermal electrolysis, is a rare, life-threatening type 2 hypersensitivity reaction. These reactions are mainly caused due to a drug, or in some cases due to infection, either viral or mycoplasma. Depending on how much surface is involved, the disease can be categorized as SJS, SJS10, or 10. Typically, in these patients, it starts with a skin rash and ultimately leads to the involvement of mucous membrane of different organs like eye, oral, or genitals. If you look at the global prevalence of SJS, it is 1:6 cases per million. For 10, it is 0.4 to 12 cases per million. Though the prevalence might look to you rare, but when we look at the mortality, it is very high in these patients. Thus, it becomes even more critical for the clinicians to early diagnose the disease and minimize the comorbidities and complications in such a disease. These are the certain common drugs which have been reported in the literature, which can lead to the reaction of Stevens-Johnson syndrome, with sulfonamides and carbamazepine being the most common ones. So the disease actually has two phases, the acute phase and the chronic phase. As Sir has mentioned in his talk very clearly, that in the acute phase, what is mainly involved is the skin, where we see that there is severe detachment of the skin, followed by blistering, oral ulceration. And when we talk about the ocular surface, there is epithelial defect, redness, and photophobia, and lid margin edema. So patients who survive this acute phase, their misery doesn't stop here. They go into the chronicles of chronic SJS, where we see that these patients manifest with dry eye, fibrosis, similar formation, and keratinization, which ultimately, if untreated, can lead to vision loss and corneal blindness. So when we talk about the molecular mechanism, for a clinician, we might say this is skin detachment. But for a molecular biologist, we always see that this skin detachment is actually death of the cells, which are keratinocytes. So there are many immune cells which have been reported typically in the acute phase, which can actually lead to the cell death of the skin cells. Some of the major key players are cytotoxic T cells, NK cells, and monocytes, which secrete certain cytokines like TNF alpha, annexin, perforin, granzyme B, and granulins. So these all pathways can actually lead to the cell death of the skin, and ultimately which is manifested in form of skin detachment. The bigger question which everybody had previously with Dr. Sangwan's talk was, how do we cater to this? What is the mechanism by which we can actually stop phenomena of ocular manifestation? So one of the thesis work of a PhD student, Karthik, is actually to understand this part only, where and what pathways to actually target so that the patient doesn't enter into the chronicles of chronic SJS. So to understand this question, what we started doing was, first we set up a collaboration with RML Hospital, with the dermatology department, which was actually giving us the tear samples from these acute patients. And we were collecting the tear samples from the chronic patients of SJS from our own hospital and some healthy volunteers which were age matched. So the first thing which we did was we did an extensive cytokine and chemokine analysis of these SJS patients in their tears, both from acute and chronic phase. What we actually found was there were certain cytokines which were common in both the phases, like typically IL-6, IL-1 beta, MMP12, TNF alpha. They were all common, as you can see, in chronic as well as in the acute phase. But there were certain cytokines which were distinct to both the phases. To correlate, if I draw your attention to EGF, EGF is actually down regulated in our data set, which is actually very correlating with what Sir said. The main problem in chronic phase is epithelial defect, and EGF is one of the factor which actually plays an important role in wound healing. And we have a clear evidence here that because of low expression of EGF in the patients of chronic SJS, this might be one of the mediators why the cornea is not healing and the epithelial defect is still persistent in these patients. Henceforth, it becomes really important that whatever we see clinically, we translate that knowledge into the lab, where we can actually look at the key pathways or molecules which are mediating the disease and causing still low-grade persistent inflammation in these patients. So Karthik will actually, during his PhD, delineate this whole mechanism, and we would try to bring in some drugs which can be repurposed to target these mechanisms. So we all know that SJS is not caused in all the patients. It is a very few people who actually show a reaction. So that clearly indicates that there is some genetic predisposition in some people who actually give a reaction. So the one predisposition which comes in mind of everyone would be HLA allele. Are they associated to cause an extensive immune reaction in patients? So my answer to you would follow in the answer to this question would follow in the further slides. So the first study to actually address this question was conducted in 1987, where in the European population, in the survivors of 10, 44 patients were recruited, and wide genotyping of HLA-A, B, and DR was done. And in this study, they found a close association of HLA-B12 with SJS, typically which is caused due to sulfonamide and oxycam, thereby setting a ground that HLA does contribute to a severe drug reaction. Followed a few more studies, which was clearly shown where in Han Chinese population, in Thai population, Malaysian population, there was a strong association of HLA-B1502 with an SJS, which was actually induced by carbamazepine drug. But this HLA-B1502 was not associated with European and Japanese population, but it was actually associated with some other allele, which is HLA-A3101. So this study was actually conducted in a larger cohort of samples, so a strong association was found. So gaining this knowledge, people didn't stop at the lab. In Taiwan, Singapore, Hong Kong, and Thailand, the government has actually incorporated the genotyping of this HLA-B1502 into the population. So here, what a clinician does is, for a patient who comes into the clinic and they feel that they have to give CBZ drug to that patient, they actually prescribe the genotyping of HLA-B1502. If the patient comes positive for it, they give an alternative medication. While if the patient comes negative, they prescribe CBZ drug to the patient. So by incorporating this genotyping, Taiwan has actually reported decrease in the incidence of SJS because of CBZ, thereby highlighting that the strength of genotyping which needs to be incorporated. So this is, we're talking about the non-Indian population. What is the status of HLA typically with regard to CBZ drug in Indian population? So here also a few handful of studies were conducted in isolation with either South Indian population or North Indian population, and they found that the allele frequency of HLA-B1502 was very low in Indian population, which was very high, as you have seen in the previous slide, in Taiwan, Thai, and Malaysian populations. So that means if this frequency of HLA-B1502 is low in Indian population, there might be some other gene which is causing CBZ-induced SJS in Indian population. So another two studies were followed up in 2017 and 2019. where they found out that HLA-A 3101 and HLA-B 5701 were alleles which were mainly associated with SJS that was caused due to CBZZ. But the question now arises is, why is this genotyping still not approved in India? So the reason is there is still lacking strong evidence in Indian population which actually strongly associates these two diseases with CBZZ drug induced SJS. So the few reasons for this is, all these studies which have been carried out in the Indian population, firstly, has been carried out in a very small population size. Secondly, they have all been carried out in individual centers. And individual by centers, I mean either in South India, either in North India. So there has not been a holistic study which has been carried out all throughout India where we can actually look at the allele frequency. So here lies the gap in the knowledge, and where we as a society needs to pitch in, where we have to put our hands all together, collaborate, and build up this ecosystem where we can actually understand what allele frequency is being prevalent in the Indian population and which is being associated with SJS. So this we talked about the CBZ drugs. So now next, there were other reports which have been widely been published by Miami group, Miami and Kinoshita group, where they have also associated the allele HLA-B 4403 in Indian population, Brazilian, Korean, and Japanese population. So this study was actually carried out in Japan, and they had collaborated with different countries. Typically for India, they had collaborated with LVTI1 and Sion Paso for collecting the Indian samples, and they had collaborated with the other institutes from Brazil and Korea, and they had found that there is a strong association of HLA-B 4403 with cold medicine related Stevens-Johnson syndrome. So thereby, these studies which we have pulled out from the literature strongly support that the genetic predisposition does play a very important role in Stevens-Johnson syndrome. So this year, earlier we had talked about the HLA alleles. What about non-HLA alleles? So again, the research was carried out by Kinoshita and Miyomi group, where they did a Jiva study and recruited 118 Japanese patients, and they also took the samples which was earlier shipped by Korean, Indian, and Brazilian population, and they found that IKZF1 is one of the gene which showed largest single nucleotide polymorphism into Japanese as well as Korean, Indian, and Brazilian Thai population. So what this gene actually does is, if when they have seen in SJS patients, if I draw your attention here, if the patient has or is at risk of SJS, typically this gene produces two kinds of isoforms, which is IK2 and IK1. In SJS patients, it has been seen that the quantity of IK2, which is actually the good isoform of IK, is drastically reduced because IK2 has been reported in the past that it suppresses the overactivation of the immune system. So in SJS patients, where there is single nucleotide polymorphism of this IKZF1 gene, the quantity of IK2 is less and the balance of IK1 is upregulated, which will make them more prone to SJS-like symptoms. So if I draw your attention here to this schematic, IKZ1 is very downstream of the transcription factor. So the Miami group did not stop here. They actually looked at what is the status of the upstream regulators, which is controlling IKZS1. And they also looked at toll-like receptor, which play a key role in maintaining the innate immunity. So they found out that in TLRs, so there are total 10 TLRs which are there in the literature. But out of all the TLRs, in TLR3, they found that there was gene morphism, which was found in the Japanese population. So what they did was, they didn't stop here. They actually made a mice model where they knocked out TLR3 and they overexpressed TLR3, where they found that in the mice where there was knockdown of TLR3, there was decrease in the inflammation both at the ocular surface as well as the dermal inflammation. Unlike in TLR3 transgenic mice, where there was an increase in the ocular and dermal inflammation, thereby giving them the confidence that TLR3 polymorphism is also linked to Stevens-Johnson syndrome in Japanese population. So having this lead, our second student, which is Navjot, PhD student, started exploring the role of TLRs in Stephen Johnson syndrome patients of Indian population. So to address this question, we have preliminarily taken conjunctiva samples from chronic SJS patients which are undergoing MMG or cataract surgery, and control samples were taken from the patients undergoing cataract surgery having no systemic involvement. So what we found was through PCR that in our Indian population also, that apart from TLR3, other TLRs also like 1, 4, 6, 7, and 9 were highly upregulated. Now, whether these TLRs are good or bad, we don't know till yet. So Navjot will still answer that question, that are these TLRs upregulated in these chronic SJS patient as a response, as a stress response of the body, or their hyperactivation is causing chronic inflammation in these patients is something that we will address. So from this whole literature review, what I found was there were certain lacunae which are present in India itself. First being, like in Taiwan, we have a strong association of CBZZ drug with HLA-B. Unlike in India, till date, we don't have any study which gives us a strong evidence of association of a drug with a particular disease. So we all need to collaborate, have a multicentric study where we can have a registry first, where we can document the incidences of SJS, the type of drug which is causing the SJS. So that will give us more knowledge if suppose paracetamol is a drug which is being which is causing more immune reaction into the Indian population, both south and north. So there becomes a role of regulatory authorities where we put a stop or regulate the off-the-shelf available use of paracetamol. So these are certain lacunae which I feel are present in India, where we need to translate and join all our hands together to reduce the incidence of SJS in India, where we call this disease as not rare, but in other countries we call this disease as rare. So I would like to thank my mentors and Dr. Shelda for giving me this opportunity to present today. Thank you.
Thank you, Mehak, for actually enlightening us with all these, research that you have been digging into with SGS pathology. And I just want to thank not just you, Dr. Sangwan, also, not just for being, taking this session in OGIG, but for actually setting an example of how each rare disease could have more heroes like you guys, because it is just showing that not none of the patients or with whatever rare disease should be left just like that. We need to have dedicated people who can really approach these diseases from scratch and address each and every problem and every hurdle that comes your way. And that is how it's way to go. And thank you, Sangwan sir, for showing us this example of how ये बात वही है ना कि बाल की खाल निकाल देनी है, छोड़ना नहीं है, कैसे भी करके टू टू go to the depth of the disease. And so the first part, how the clinical challenges you have faced, and now how you are trying to address it through basic research, how to prevent. And that's what the main question for everybody was there. If this is something like a drug reaction, then it should not happen. We have to stop it. And once it happens, it's very difficult to treat, as you have shown. So the way to go is to actually prevent SGS from happening. And that is where all our
And that
energy
can
should
happen
go.
only. So prevention will happen
Can I just say something?
only and
Yes, sir.
only when
Somebody is asking some question. Please go ahead. Hello. Was there a question or was any just noise?
I think Mehak was speaking, and I think.
Oh, sorry. So I just wanted to say that for everyone's benefit, that this particular talk is under our banner of Center for Unknown and Rare Eye Disease. It's called Cured. This is a new initiative that we have taken, and it's led by Selja, Abhar, Riya, and Anil. And our goal is to address rare diseases like SJS, like VKC, like aniridia, and we have disease leaders in each area, and we are hoping we got our first grant recently from a Swiss agency. So we think that we will be in another 5 to 10 years will be having a very good system of addressing these rare diseases. And in this, I think SJS would be the lead. So now please ask any question, anyone who has about the mechanism. I have a lot of questions, but I will ask you, Mehak, when we meet. I will allow others people to ask questions or make comments. Sales is all yours.
I have a question.
Yeah, Ria, please go ahead.
I wanted to ask, so HLA typing is done for a lot of other purposes also. So, and you showed that there is a specific allele of HLA that in some populations has been proven to be associated with susceptibility to SJS with certain drug combinations. So, without actually doing further interventional GWAS or that kind of screening, do you think we can extract data from previously done HLA studies and see if that allele is occurring in our population just from the databases and existing literature? Do you think that can be dug out?
We can do that, but like I showed a very clear example of carbamazepine.
Mm.
There it was clearly shown that whatever allele is specific to the Taiwan and the other population, that particular allele is not coming in.
In
Mm.
Yeah.
Hmm.
So
But
the
Ria,
So I
but
think
yeah,
altogether we
having
need to have a consortium that
go
are
ahead, sir. Go ahead, sir.
database.
yeah, so having a association does not mean it's a causality.
Yeah.
Like actually B27 associated uveitis is just simply an association. It is just like Abha or Nia are seen together doesn't mean they just have an association.
their sisters.
Yeah.
Yes.
Doesn't mean they're plotting something.
Yeah, doesn't mean they are on the wrong side of the law.
But
Yeah.
sir, I would slightly disagree on that part because if you look at the like I always like I'm quoting again
किसके लिए
example of
डिसएग्री कर
Taiwan.
रहे हो ये तो बताओ पहले.
HLA
Sir, like
typing के लिए.
the HLA typing, like for
तो
Taiwan
टाइपिंग के
population.
लिए डिसएग्री नहीं कर रहे हम. करो
Really, but there is an association of, but I would say yes, there's not just HLA which is responsible for, that's not the only sole allele which is responsible for the immune reaction. There are many other non-HLA types like IKZ, and they are now being reported that drug metabolism related genes like cytochrome 450, people are now reporting that also to be associated. So it's not
Yeah.
just the allele, but yes, other non HLA alleles also which are being associated. And definitely, I strongly believe that we need to make that database. And that is the only way ahead where we can reduce the incidence of the disease in India. And for that, we need to genotype the population both of North, East, South, because the allele frequency because the diversity in itself in India is so vast that we need to genotype all of them. So like it's like a consortium needs to be made, and I think Cured would be a very good platform where we have that center build, where everyone collaborates, all the centers collaborate, and if they don't want to send in the samples, but they can at least we can have a data sharing where we know the incidence which is being reported in that particular hospital. At least a database or registry will start being built, like to build a registry also. When you look at PubMed, you would find very handful of papers related to genotyping of Indian population, or if you will find, they will be done in 10, 12, and they are very small numbers to actually form a strong association with
Fine.
any
I
drug.
think, Selja, there is a question in the chat. Please
Yeah.
first attend to that.
So
Varsali is asking.
Yeah.
Shali is asking, is there any correlation with the underlying systemic allergy? Do you think?
If Varsali is there and you can unmute her, maybe she can clarify what does
She
it
can
mean.
unmute herself.
Yeah,
Rushali, are you?
so yeah, can you hear me?
Yeah, yeah.
Yes.
Yeah. Sir, in day-to-day practice also, many times we see initially patient is not allergic to that medicine, but afterwards maybe patient shows allergic to. For example, if for a tropic acid plus, initially patient is not allergic to that, but later on patient shows allergic to that. And systemically also patient maybe they have taken an antibiotic before, and then for a second time or third time body reacts to the antibiotics. Or for anaphylaxis also, suppose I know few of the patients who has been taking penicillin and they are tested for the dose and all, but still they have got an fatal anaphylaxis for that medicine. So is there underlying chronic inflammation is going on, and by some it is triggering and then causing a severe immunological reaction. So is there any correlation has been noted for that, any systemic allergies or any other systemic allergies, and then patient has gone allergic to the medicine, like?
So, Mike, do you have any comment on this?
Yeah, so ma'am, if you talk about or if you look at the molecular mechanism of SJS, it's a type 4 hypersensitive, delayed hypersensitivity reaction. So it has been reported in patients. In some patients, even the first dose of, suppose, an antibiotic can give a reaction as early as 1 day or as delayed as 30 days. While in some patients, maybe that same particular drug, not with the first, but maybe third, fourth dose, is giving an immune reaction. So depending upon the patient in itself, it's a delayed hypersensitivity reaction. So a patient can give it is not an underlying allergy. It is the response or reaction of the body to that particular drug. So it can be as early as 1 day and it can be as delayed as 30 days by exposure to the same drug.
Yeah, Varsali, you rightly said that you may not have allergy to the same medicine and earlier and then develops. This is quite common. But if you have an allergic predisposition, or if your immune system is overly active, then
Yeah, exactly.
then it's likely to react. But I don't know of any correlation or any good study which documented specifically the question you're asking.
Sir, can I add to this?
Hmm.
Yeah. So as Mehak has pointed out, the genotype, they basically genotyping, finding the HLA and other mutations, it's also plays making you susceptible for any sort of allergy or anything. So maybe if you are not having that mutation, some concentration is not lethal. But if you have some mutations, even the lower concentration of the drug which you are taking, because drug takes some time to reflux from your body, that may build up and actually cause the hypersensitivity. So it's a complex thing. And when we understand from different angle, like genotyping, the drugs and other, this will be useful.
All right.
Yeah, that probably makes us think that maybe this factor should also be considered when you are collecting data or analyzing your patients for genetics, that whether the reaction came in the first exposure to the drug or with subsequent exposures. Because, I mean, this could throw some light to why some patients have reaction at the first encounter and why some have delayed hypersensitivity.
No, and the other thing that also holds a role is spurious medication, because it's not always the drug itself, it is what the preservative that is with it. Even there is another
Correct.
comment in the chat which says different brands can cause problems. Like
Yeah.
Dr. Sangwan mentioned in the previously also, there in India, if you see, it is not very highly in the it is not seen as much in the higher socioeconomic strata, probably because of the access to better medications. And that is something which still needs to be seen, that what exactly it is. Probably carbamazepine or paracetamol mixed with something is causing that effect. Sir, would you like to?
Yeah.
No, I think it's fine. We discuss different aspects, and if there's no other questions, we can basically break for dinner.
Yeah.
Anyone, if you have any further comments, questions, Otherwise, we really enjoyed and
has mentioned many times the patients are not even aware of what medicine has triggered it. And that again, maybe would be because they have been given over-the-counter medications, which they do not really know.
Over the counter, yeah.
Yeah, and also another confusion, like you get a flu-like symptoms and you get fever, you get a medicine. So you don't know whether these medicines cause the reaction or
Or
whether
the
it is the fever, like viral, mycoplasma.
Fever.
There are variety of things that we are getting now clarified that
Yeah.
sometimes the confusion is real. It's not necessary that it is clearly you can establish a drug as etiology.
Yeah.
Yeah.